here, and we're going to talk a little bit more about how to save the leg and save lives in persons with diabetes. So now we're going to be talking about diabetic foot infections, how to protect, how to prevent them, how to treat them, and what we all need to do. Our objectives are basically to look at what diabetic foot infections are, what the impact of diabetes or uncontrolled diabetes is on those infections, what type of, some examples of some infections, as well as what we need to do to prevent and to treat them. So diabetic foot infections are among the most frequent diabetes-related complications and the cause for hospitalization. It also increases or causes the stay in hospital to be longer. And in fact, 85% of our amputations are preceded by ulcers and infections. So there's a range from a superficial, one of the other speakers talk about a nail infection or paronychia. And so the infection can range from as simple as a little redness on the nail, for example, an ingrown toenail, straight up to a bone infection. So we can see that this can have very far-reaching results. As well, these infections can be classified as mild, moderate, and severe. And so we're going to talk a little bit more about those. So some of the types of diabetic infections we talked about, for example, we talk about cellulitis, or redness in the skin. Most persons would know it as that. We talk about the ingrown toenail. If you've ever had an ingrown toenail, you know exactly what it looks like and what it feels like. So that redness that you see, drainage that you may see, all of that is infection. Having abscesses or having tendinitis or even a bone infection, those are all examples. So you can see on the slide, we have a number of those examples of what infections would look like. So we know that diabetes is a challenge because of the persistent high blood sugar. And once you have high blood sugar, that impacts all parts of the body, including the immune system, which is responsible for dealing with infections. So once you have high blood sugar for a long period of time, you have neuropathy, which can alter the shape of the foot, the feeling in the foot. Dr. Johnson mentioned before, persons not being able to feel or touch or know that they received an injury. So all of that is related to the neuropathy. Dr. Parkinson spoke about the vascular insufficiency or not having enough blood flow to the toe or to the feet. And so this also can be a result of that high blood sugar. But one of the things that directly relates to diabetic foot infection is the immune system, and that is the neutrophils. You know, it has been well documented that once the HbA1c, which is the test that tells us how well your sugar is controlled, once that is elevated, especially if it's above 10, 12, which a lot of our people have high A1Cs, the neutrophils, or the cells that actually fight infection, do not work as well. Another way that our immune system is depressed or doesn't work as well is consumption of sugar. A lot of persons like to eat sweets or a lot of sweet foods, and so that also can impact how well the immune system can work. So more than 50% of all foot ulcers will become infected, and persons would need to be hospitalized. That's 50%, that's half, okay? And then out of that, those persons, 20% may lead on to an amputation. So we see that this infection has serious consequences. So why do persons get these infections? Why is Ms. Jones at a higher risk of getting an infection than Ms. Butler? Okay, so some of the things are, if Ms. Jones walks barefoot, she likes to walk barefoot in her house, either indoor or outdoor, could be one of them. Some of her personal status, like her renal status, or if she has neuropathy, she may have a vascular problem we spoke about as well. Those all increase the risk of her getting this infection. Having had a previous infection or an amputation before also increases the risk of getting another diabetic foot infection. Having an ulcer for more than 30 days. And so we can see most of the staff here, or most of the persons who work in this field, 30 days is nothing. You know, persons have ulcers sometimes for years. And so having an ulcer for more than 30 days also increases the risk of someone getting a diabetic foot infection. Now, the first one, I'm saying it last, but it's the first one, is a probe to bone test. Okay, this talk will go to the lay people as well as professionals. So, but most of the persons who work in this area, I guess, would know this, but it's very simple. If the person comes with an ulcer, and you can put a sterile probe or a Q-tip or something like that you can put inside the wound. And once that goes in the wound and it touches the bone, no flesh or anything in between the outside and the bone, that is called a probe to bone test. And if that's positive, meaning you can do that, then that increases their risk for infection. So all of these factors here can do it, especially trauma. If you hit your foot or you got hit, you drop something on it and it opened the skin, that also will increase your risk for infection. So diagnosing an infection, what do the doctors do? When you go to Dr. Farquharson or myself or Dr. Johnson or someone else, they're going to look at the foot and see exactly what is going on. Do you have classic signs of infection? Okay, redness, pain, swelling, warmth, drainage, any of these things, especially if it's pus or a bad smelling odor. Sometimes the patient already noticed because they either saw it on the tile or they saw it on the socks or the family member actually told them. So most persons with diabetic foot infections have a local infection, but some people can have a systemic, meaning the whole body can be involved. Okay, this can lead to delayed wound healing. So you're doing everything as a primary care physician. You're seeing this patient weekly, you're cleaning the wound, you're doing everything, and this wound is still not healing. That should be an indication to you that maybe something else is going on. It's either a vascular problem, it's an infection, or something is going on. So you need to do that, go the extra mile and check. It might be an infection there. And then the last one is systemic signs of infection, including fever, chills. It could be elevated blood sugar, because the high blood sugar over time impacts how well the immune system works. So sometimes they may not have fever, chills, and all the classical signs of infection, but the blood sugar may be the indication that tells us that they have an infection. So to diagnose that, we will do what is called a wound culture. We take a little bit of the tissue that's in the wound after it's cleaned, and we send that to the lab, and they will check to see what microorganisms or which germs are growing there, so that we can see exactly how to treat it. Okay? So these are the most common types of bacteria that actually cause diabetic foot infection. Staphylococcus aureus is the most common bug in the world, and so it's also the most common one that causes diabetic foot infection. But most diabetic foot infection has more than one germ or bacteria there at the same time, but this is the most common one. So other things that we do to diagnose a diabetic foot infection would be, for example, that probe to bone test we talked about a minute ago. We can do x-rays, MRI, other scans that will show us exactly what's going on. For example, this slide here, you may not see it well, but that one there shows us an example of a Charcot foot where the bone is protruding to the bottom. The top one shows us gas in the tissue, that's showing pus actually in the tissue, and this top one here is showing the probe to bone test. So microbiology is what bug is growing there, what is causing this infection. So I won't go through all of that, but basically we know Staphylococcus aureus and beta hemolytic strep, just like you would have a strep throat. You remember that back in the day? Our parents used to say that. So the similar bacteria like that, okay, would cause the most diabetic infections. And then you can have deep infections. You can also have MRSA or methicillin-resistant Staph aureus. This is just a classification of how we know what level of infection you have. This I'm not going to go through at all, but you can have uninfected, okay, where the wound is not infected at all. It can be a mild infection, and then it could be moderate, and it can be severe. Okay, so based on the classification, then we will treat the person accordingly. So I want you to read with me. What does that say on the top there?
No infection, no antibiotics.
Excellent. So no infection, no antibiotics. So those pictures there, you can see they do have a wound, but they're not infected. Okay, they're stable, they're not infected, so they don't need antibiotics. But of course, the patients come and they want something, they want the antibiotic, so we must be able to tell them, no, you don't need any at this time, okay? So on these ones here, you can see that there's a little mild redness around the wound, so they would be considered a mild infection, okay? So that would be what you would be consider, okay, let's see what we need to give them. Maybe a first line drug or something like that. This one here, you can see, especially the little toe there, the redness is a little bit more, it's deeper, and you can see the tissue there, it looks a little bit traumatized. And then this one here on the toenail, you can see that there's actually a hole in the toe that's poking down below the nail. So both of those are considered moderate infections and will definitely need some antibiotic. Now this one are severe infections, okay? The whole foot is almost red. You have tissue that's dying, you have pus draining out of the foot. All of these things here can actually cause you to have major problems. So before treatment, you would make sure check the patient to make sure that you are assessing the patient as a whole, not just the foot. You're testing the person, you're checking the foot, and you're checking the wound, okay, to make sure. You would debride the wound, any additional tests that you would need, you would also do those. Okay, so for treatment, we talked about it already. No infection, no antibiotics, okay? The guidelines we talked about earlier is talking about antibiotics that guide the treatment. It tells us what medication to give if the person has a mild, moderate, or severe infection. And so that would help us. But basically, the culture tells us what to give them. This is just an example of how detailed those guidelines are, and we have access to those. So osteomyelitis is an infection of the bone, okay? And so once that happens, there are more things that we need to do because there's always a possibility of having to have surgery or more aggressive treatment with the antibiotics. So that definitely is. So my second to the last slide is, as we talk about infections, we realize that everybody has to be concerned about this. Dr. Johnson mentioned about the red light, green light, red, amber, and green light, okay? So with the same thing with the infections, we definitely need to know what level of infection the person has and how to treat them. The multidisciplinary team, the foot team that we're talking about today is bringing all of us together and making sure we're on the same page and that we can all treat and make a positive impact in the life of this person. And that team requires all of us working together. And so my last slide is, what is the role of the patient and the family? I'm sure if you saw that slide, you looked carefully in that slide before, the patient was actually in the center of everybody else who was working for them, okay? So the patient has a role too. You have to prevent these infections from occurring in your foot, okay? And the first one is to make sure you check your feet every day. No barefoot walking, okay? Making sure that you're doing the things, no soaking your foot, not causing injury to the foot, okay? All of these things will prevent. We talked about the risk factors. If you prevent them, you will not get an infection. And then if you do get something, because you're looking at your foot every day, you will notice it quickly and you'll be able to get help, okay? You need help because of the diabetes may be out of control. You may have neuropathy, you may have a vision problem, you may not be able to see as well to clip the nail, you miss and clip yourself a little bit on the side, okay? You may have arthritis, so the hand doesn't work as well, and so you're not able to do the things that you would like to do. And then you need to see a podiatrist regularly to have your feet checked. Donnay came up earlier and she talked about medical pedicures. That may be something we can incorporate into your care so that your nails are always in good condition. But seeing a podiatrist regularly is very, very important to save your leg and to save your life. And if we don't do that, and if you don't do your part, then we are not going to be able to control these infections. Thank you so much.
Questions?
If you have no questions, I have a question.
Go for it.
Okay, so we talked about some of the risk factors. Can somebody tell me two of the things or the risk factors we talked about? why someone would get an infection. Tell me 2 things why any diabetic would get an infection.
Get stick on the nose.
Okay, trauma, excellent. One more.
Anything that causes the skin to be broken, anything that breaches the integrity of the skin.
Yes. So trauma would be anything that would cause you to get a cut, but it can also be related to you as a person, okay? Is your sugar under control? Okay? Do you have kidney disease? Do you have any other factors that contribute to why you would get an infection? Okay? You're eating too much sweets, you're not taking your medication, you're not sleeping, you're not exercising. All of these factors can actually lead to you getting an infection. But we want to prevent them and to make sure that you save your leg and save your life. Thank you so much.